Hello, everybody, and welcome back. We are talking about pregnancy as a special population. We have Sarah, who came in for physical therapy because of hip pain. And this lecture, the purpose of it is to make sure that we as physical therapists appreciate the unique physiology of the pregnant patient, especially as it applies to how we prescribe exercise. So the first video was all on how pregnancy changes the cardiovascular system. And the first half of this video, we're going to now look at the respiratory system. So I think this is a great picture to truly appreciate the impact of the size of the baby on the woman's anatomy within the gut. But really specifically, this is talking about the lungs. So let's focus our attention on that diaphragm, our primary inspiratory muscle. On the non-pregnant lady over here, you can see the diaphragm is this nice dome-shaped muscle. And the reason that it's a dome is so important because as the diaphragm contracts, it's going to pull down. And as the diaphragm contracts and pulls down, it's going to increase the volume of the lungs. By increasing the volume, you create a negative thoracic pressure, and that's how we suck air in. Primary muscle of inspiration. Now look at the diaphragm in the woman on the right who is pregnant. The baby has pushed all of the internal organs upward, and it's actually elevated the diaphragm. On average, the diaphragm is pushed upwards by about 4 centimeters. So how is this going to impact breathing? We know what's normally supposed to happen. How is it going to be different once there is a baby on board? The big difference is when the diaphragm needs to contract and descend, when it needs to go down, when a woman is pregnant, there is now resistance against the diaphragm. There is a force that has to be overcome in order for the diaphragm to descend because all this is being kind of shoved up against it. So during pregnancy, the diaphragm has to push against resistance in order to flatten, to create that increased volume to allow the air to come into the lungs. And this increases the work of the diaphragm. Basically, for the same amount of air being pulled into these two lungs, the diaphragm on the right is working harder. If a muscle is working harder, it's going to have a greater oxygen demand. And we see that increased oxygen demand of the diaphragm during pregnancy because oxygen is how our muscle cells create ATP most effectively. We need ATP to fuel the machinery of the muscle in order to now contract against a resistance. So let's look at the measures of breathing. And with breathing, we talk about minute ventilation, the movement of air into and out of the lungs by bulk flow per minute. And if you're not as comfortable with minute ventilation or the concepts of it, it's really helpful to just apply this to what you already know in the heart. Cardiac output equals stroke volume times heart rate, I hope is an equation that you're very comfortable with from physiology. Minute ventilation is really the equivalent of cardiac output, except we're in the lungs, right? Instead of how much blood is being pumped out per minute, how much air is moving in and out per minute. That's minute ventilation. And the components that come together to form the minute ventilation is VT is tidal volume, which is the equivalent of stroke volume. For each individual breath, what is the volume? That's tidal volume. And then F is the frequency, which is the heart rate, equivalent to the heart rate. How fast are you breathing? How many breaths per minute? So as you can see in your notes, minute ventilation during pregnancy increases by about 40 to 50%. And let's just look at what those numbers actually look like. For a typical 70-kilogram man, which I regret that it's a man, but almost all of our physiological normative data is from a 70-kilogram man, so we're going to have to use that. Minute ventilation is, on average, about 7.5 liters per minute. Our tidal volume is around 500 mils, or half a liter. And frequency, kind of on average, 15 breaths per minute. So that's a normal non-pregnant person. It would be very tricky if this man somehow got pregnant. Let's compare that to a pregnant woman, individual. I guess I shouldn't just write pregnant. I'll write pregnant woman. I was going to end at pregnant, but that doesn't feel right. Okay, so if the pregnant woman has an increase in minute ventilation by about 40 to 50%, then at rest, we're talking about 10.5 liters per minute ventilation. And tidal volume does go up. It's typically around 0.7 liters, so a little bit higher than a typical resting individual. But the frequency, the breaths per minute, stay the same. So the pregnant woman is accomplishing this increased demand of oxygen through volume over frequency. And by using volume over frequency, that is a more energy efficient way to get oxygen into the body, because you have dead space air that you're just moving in and out. So if you just increase frequency, you spend a lot of energy just moving dead space air up and down. If you can increase the volume, that is a more efficient way of increasing your minute ventilation. So we're talking about this because we want to be able to prescribe exercise. So let's look at what happens to minute ventilation during exercise. And in order to talk about how the respiratory system during exercise will be affected during pregnancy, let's just make sure we all understand what happens normally. And so normally, as exercise intensity increases, so does minute ventilation. And on the previous example, we had said that minute ventilation at rest is around 7.5 liters per minute. When you get to maximal exercise, depending on the person and their body, you can see minute ventilations from 120 to 175 liters per minute. So from 7.5 liters per minute to 120 to 175 liters per minute. Isn't the human body amazing? Can you even believe this? I can't believe it. It's incredible. So let's look at how we do it during exercise. What components of minute ventilation do we access to make this huge increase happen? And before I talk about these graphs, which are in your notes, I just wanted to point out your x-axis is labeled incorrectly in your notes. It's listed as milliliters per kilogram per minute, and it should be a percent of maximal VO2. So at the end of the x-axis, you're getting to your VO2 max. I apologize for that error in your notes. So we can see, we said minute ventilation can increase. Let's just go on the low end, okay? Let's just say it can increase to 120 liters per minute, although truly some athletes are showing 175 liters per minute. I just had to write it down because it's so amazing. Okay, how do we do it? Well, unlike the heart, we actually accomplish this differently. So we used the analogy to the heart of cardiac output equals heart rate times stroke volume, but I don't want you to muddle that, or confuse maybe is a better word. I don't want you to confuse that the responses would be the same to exercise just because the equations are similar. So what we see is initially there is this sharp rise in tidal volume. So at the beginning, when you're raising your minute ventilation, you're doing it with volume. So if we had max exercise, minute ventilation of 120 liters per minute, you might see tidal volumes around 3 liters, right? Resting is around 0.5 liter. So we first really kick in the volume first. As exercise intensity increases and becomes more and more intense, or in kind of also seen more in more sustained exercise, we start to see an increase in frequency, breaths per minute. So at the higher intensity levels, then you're going to tap into frequency second. So if the lower intensity exercises, very modest or almost no increase in frequency, we accomplish our increased oxygen demand with volume over frequency. but as exercise intensity gets high enough, we will use frequency to move all that air. And if our max exercise is around 120 liters per minute ventilation, and we're breathing 3 liters in and out, that's a respiratory frequency of around 40 breaths per minute. So it can really get high to accomplish, this big uptick in minute ventilation. This graph is just another way of looking at the same thing. The first half is just showing you some of your volumes as a refresher. And I like this because you can see how little we use at rest. Our tidal volume uses a very small capacity of our lungs. So lungs are rarely the limiting factor during exercise because we have this huge reserve. If you remember, from the end of tidal volume to residual volume, this is all of your expiratory reserve volume. So you could breathe out a lot more than you do. But the other side is even more dramatic. If you compare your maximal inspiratory volume to the top of your tidal volume, we have a huge inspiratory reserve. We can take in a much larger volume when we need to accomplish the increased oxygen demands of our body. And if you head to the right, you see different degrees of intensity of exercise. You can also see the frequency of the breaths by how narrow the wave is. So during light exercise, we have almost no change in frequency. We just start to dip into those reserve volumes, typically the inspiratory reserve volume. And then as we get more intense, we keep going for volume, and eventually we have to increase the frequency. We do this in order to move enough oxygen into our body to feed the machinery of our muscles. So at the very bottom of your note page, it says, why does minute ventilation increase during exercise? And it all comes back to this interrelatedness of all the systems in our body that are working together to move oxygen to ultimately get it delivered to mitochondria to make ATP. So during exercise, physical activity both increases oxygen consumption as well as increasing carbon dioxide production. Exercise increases oxygen consumption and CO2 production more than any other physiological stress. Exercise is a huge stress to our system. And proper ventilation, being able to increase the movement of the bulk movement of air in and out of our body, is necessary to fuel this and also to maintain proper gas concentrations in our lungs, to have the oxygen available in the blood right where you need it. So let's bring this back to pregnancy. We said we have to understand what happens normally to know what's going to happen during pregnancy. What are the implications if we ask this person to exercise? Well, I would expect increased work of the diaphragm because there is resistance to the diaphragm that the muscle of the diaphragm has to overcome in order to do its job. This patient would already have increased minute ventilation at rest because the pregnancy is increasing oxygen consumption and CO2 production. So they're already kind of tapping into their reserves. And the way that a pregnant person increases their minute ventilation, one of the ways, it's more complicated, but progesterone actually stimulates central respiratory centers. So that progesterone has just so many roles to play during pregnancy. The other thing that is important to think about when we're looking at the anatomy of our pregnant patient, when this baby is pushing everything up, and we mentioned the implication of that on the length tension relationship, or the amount of work, I should say, that the diaphragm is being expected to do, it also spreads the ribs out and it increases the rib cage dimensions. So how do these changes affect some of the volumes? Well, there's actually a normal total lung capacity during pregnancy. One might think that it's reduced because of all this upward pushing, but the spreading of the lungs allows for a relatively normal total volume as well as a relatively normal vital capacity. And if you remember, vital capacity is the total amount of air we have access to, right? If you go from a full inspiration to a full exhalation, their vital capacity is actually considered or is the same during pregnancy, which is actually kind of amazing with that baby there. What is affected is the functional residual capacity. If you remember, this is the volume of air that's left in the lungs at the end of a tidal breath. An exhalation is a passive process, and the reason we stop exhaling air is because there's that balance between the forces of the lungs, the elastic recoil wanting total collapse, and the chest wall wanting to be at about 60% of its capacity, and they're suctioned to each other. So as air leaves and there's this inward force, eventually the outward force of the rib cage is exactly equal and opposite to the collapsing inward pressure of the lungs, and no more air leaves the lungs. And that naturally occurs, and that creates the volume of FRC, functional residual capacity. So with all of this stuff pushing up at the end of a normal breath, there's an additional force pushing air out and creating an inward force, and that ultimately lowers their functional residual capacity. This isn't a huge factor. The biggest place this comes into play is that this becomes more exaggerated and dramatic when this woman is supine, because that just pushes more of that upward. You don't have the effect of gravity pulling this down to help offset. So when they lay flat, there's an even greater effect and a more dramatic drop in FRC. So when the patient is supine, this can actually cause what's called atelectasis, or collapse of your small airways, and they can actually become hypoxemic in supine. So this is just one more reason that supine is not a great position later on in pregnancy once the baby is bigger. We talked about in the cardiovascular system because of the impact on venous return and potentially compromising cardiac output. Now you can see there's also an impact on the lungs because it's pushing so much air out. You're collapsing some of the lower airways and maybe inappropriately oxygenating the blood. Okay, so we've talked cardiovascular, respiratory. Now let's actually think about prescribing some exercise to a lady who is pregnant. First, let's go with the absolute no's. So women that would be considered a contraindication to exercise is multiple gestations. That means they have They have more than one fetus. There's just not enough data, and the risk of early labor is concerning, so exercise is contraindicated. An incompetent cervix is when there's early cervical dilation or effacement. That's not something you would be assessing, but if they go to their doctor and get diagnosed with an incompetent cervix, they would no longer be exercising. Placenta previa is a condition where you have a very low placenta that's covering the cervix, and that would make it a high risk. Preeclampsia and pregnancy-induced hypertension, if there is persistent second and third trimester bleeding, and if they have a ruptured membrane. All those would be no-nos for exercise. There's a relatively short list of relative contraindications, things that should give you pause and make sure that you really think through the risk-benefit of exercise. Severe anemia, the fear there is compromised oxygen delivery. Poorly controlled type 1 diabetes, morbid obesity or extremely underweight. We don't want to be straining the system. History of an extremely sedentary lifestyle, heavy smoker, or poorly controlled hypertension. All things to consider. All right, so those are the absolute no's. I want to add one more piece to the puzzle, and that is the regulation of heat. Are we concerned at all about how the body might be affected during exercise when it comes to heat? So what normally happens when any person exercises? The normal thermal effect is that as we exercise, we create heat. In fact, your internal temperature is directly proportional to exercise intensity. As you increase your VO2, your temperature will go up. And this is not increasing heat. Internal heat is the normal response to exercise. This is not a failure of your heat dissipating mechanisms, but rather it serves a functional purpose. Right? We've actually already talked about it, right? Why do you think heat is a good thing? It improves oxygen delivery through the Bohr effect. You can improve viscosity and flexibility of your connective tissue. It's going to increase nerve conduction velocity. It'll increase the rate of myosin ATPase. You can increase the speed of muscle contraction. So we already know that for a normal, healthy person, heat is good. But this graph is one of the main reasons that the old school way of thinking was to tell pregnant women not to exercise because they were concerned that the increased temperature could hurt the baby. So you already know, spoiler alert, that exercise is safe. But it is important to take into account how the patient in front of you is handling temperature. And this goes for a number of different patient populations, certainly not only pregnancy. But let's just make sure we are comfortable with how our body is dealing with all of this metabolic heat that we're creating. Remember, exercise is this serious challenge to homeostasis, and these large muscle groups generate a ton of heat, and then blood drains out of these heat-producing muscles into the circulatory system, and it transfers that heat everywhere in the body. How does our body attempt to handle this huge imbalance to homeostasis? Well, we have our heat dissipating mechanisms. And as you can see here, some of the big ones, evaporation. I don't know why I kind of wanted to just turn that into a rap somehow, but I am no rapper, so I will move on and hold that one into the vault. Evaporation is the heat loss when water on the surface of our skin changes to a gas and takes the energy that it used to convert from a liquid to a gas with it, and voila, we lose some of our heat. Radiation is the transfer of heat from one surface to the other without physical contact. So at rest, about 60% of heat loss is due to this radiation, or what's known as the thermal gradient. Kind of what's the difference between the temperature outside of our body and the temperature inside of our body? If there is a greater difference, there will be a greater, I shouldn't say that. If the outside temperature is colder, there will be a greater difference between the outside temperature in our body, and we will lose heat faster. Convection is the transfer of heat to air or water touching our body. So as the air flows by us, it takes the heat with it. And conduction would be transfers with direct contact. So I said that at rest, most of our heat loss is through the thermal gradient of radiation. But what happens when we are exercising? And this graph is showing what's happening when you're exercising in different temperatures. And this is really interesting. So here you can see the energy being produced, showing that the body is exercising. Here's the heat production associated with it. So the amount of energy produced and heat produced doesn't change based on the environment around us. What does change are our heat dissipating mechanisms. So in colder temperatures, when there is a greater difference between our body's temperature and our environment, there is a greater reliance on radiation and convection. As the temperature gets hotter, as it gets heated up, there is going to be less and less of a difference between our body temperature and our environment around us, which will make radiation and convection less effective at dissipating the heat. So as the temperature goes up, we are going to rely much more heavily on evaporation. So when you're exercising someone, you know the exercise is going to generate a heat, and that heat is directly proportional to exercise intensity. So the more intense the exercise you're prescribing, the more this heat question and their ability to dissipate heat is going to rise to the level of concern or something you should be thinking about. Whenever you are prescribing exercise, especially higher intensity, you want to think about the environment that your patient is exercising in, because it will matter a lot as to how well they tolerate the exercise. So their environment matters. Their individual effectiveness for dissipating heat also matters a lot. So fat is an insulator. The more fat someone has, the worse they're going to be at heat dissipation, because that thermal layer of fat will help hold the heat in. Women in general have more fat mass than men, so that is something to be more concerned about, but certainly once we get into our obese populations, this can be a large concern if we are prescribing exercise, intense exercise in the heat. How well your body dissipates heat is affected by what's called acclimatization. If you exercise in the heat every day, your body will get better at managing the heat. Your heat dissipating mechanisms will improve. So when you consider the individual in front of you, if they've already been doing intense exercise and you live in Florida and they are outside every day, it's less of a concern because their body has gotten acclimatized to the heat and they're already improving their ability to dissipate heat. But if there's a new change, a new environment, then you want to take a little extra in account for it. So kind of what's the big deal? What's the big deal with someone getting hot? Like, what does it really matter if you rely on evaporation? Well, evaporation, again, is water molecules that go on the surface of our body, and when they get converted to a gas, the energy of that conversion is the heat from your body is dissipated. So when you are relying on evaporation, you are losing water from your body. There have been studies that have shown intense exercise in serious heat conditions can have sweat rates of 2 to 3 liters per hour. 2 to 3 liters per hour. These are the extremes, obviously, but it helps to illustrate the point. Something to keep in mind, your total blood volume is only 5 liters. Total body water is around 35 liters, but your circulating blood is only 5 liters. So what is the impact when you're exercising in the heat and you're relying more on evaporation, which is taking water out of your body? Well, you're going to decrease your total body water, which means you're going to decrease your plasma volume. So as you exercise in the heat, and the hotter it is, the more intense it is, and the longer you've been exercising, the more we're going to start to see the effects on your body water. But if plasma volume is decreasing, how does that impact the exerciser? It's going to decrease venous return. If there's less blood in the body, there's less blood getting back to the heart. If you decrease venous return, you're going to decrease stroke volume. You are still exercising, you are not stopping, and you need to maintain cardiac output. Cardiac output is heart rate times stroke volume. You just sweated out a bunch of that stroke volume. How do you maintain cardiac output to keep running in the sun? Well, you're going to need to increase heart rate. This is significant in our patient populations who may have any compromise to the heart, because the heart is working when the heart is beating. And if you have to maintain cardiac output with a very high heart rate, you're going to increase the work of the heart. Do you remember that measurement that we talked about in a previous lecture, the rate pressure product? Heart rate times systolic blood pressure. You are increasing the oxygen consumption of the heart when you rely on rate over volume, which is exactly what happens late in intense exercise in the heat. Eventually, you might not be able to keep up that cardiac output. If if the environment, if the exercise is stress enough, this effect of heart rate maintaining cardiac output can only work so far, and you can ultimately end up in hypotension, decreased blood pressure, and even circulatory distress, where you're not having enough pressure to drive the blood through the system. And this is when we see people, passing out when they're exercising in the heat, is from this postural hypotension. So these graphs illustrate this concept. Up here on the top left is cardiac output. And you can see cardiac output goes up as exercise intensity goes up. There's maybe a slight effect at high intensity exercises that you can't quite get cardiac output all the way to where you could if you were in a neutral environment. But how does the body handle maintaining the cardiac output in the heat? Well, we can see a clear effect of an increased heart rate at the expense of the loss of stroke volume, especially as you get even into the heavier, higher exercises. So the cardiovascular system is affected because as evaporation becomes the primary mechanism to manage heat production, you lose body water, which can compromise stroke volume and ultimately need a higher heart rate. Another thing to consider is that when we exercise, we need, obviously, to send a ton of blood to our muscles. We already covered this huge increase in muscle blood flow because of this massive vasodilation, because blood carries all the oxygen to the machinery of our muscles. If you are exercising in the heat, you're going to need to send blood to the skin. And blood flow to the skin is going to compete with blood delivery to the muscles. So you send blood to the skin because you to get blood to the surface of the skin to help dissipate the heat. So it's a natural effect when you're getting hot, is that you send blood to the surface of your skin. But now suddenly you got something tapping into that reserve that you needed just for the muscles. And this can compromise oxygen delivery to the muscle. If push comes to shove and you continue to exercise, your body is going to preferentially decrease blood flow to the skin in order to maintain central driving pressure, even if it means an increased core temperature. So as someone really gets far along in exercising in the heat and getting into circulatory trouble, your body will shut down this skin blood flow in an attempt to maintain central pressures. So when we talk about these thermoregulatory mechanisms, we have to go all the way to the extreme where people are passing out. But there is a lot that happens in the middle. It's kind of like muscle fatigue. You're still doing the exercise, but the muscle is fatiguing. You might not be, in circulatory compromise when you're exercising in the heat. You're not pushing yourself to these extremes that they do in studies to truly see what happens to the system, but you still can be compromising plasma volume. So it's an important thing to think about if you happen to be prescribing exercises in environments that have high heat, and think about the individual in front of you. What are the issues they're dealing with besides the reason they're exercising that might compromise their heat dissipating mechanisms, or if they'd have some kind of cardiac issue that would limit their ability to tolerate that drop in plasma volume and potentially the higher heart rate of exercising in the heat versus if they just went into a ambient environment. So since we're talking about pregnant pregnant women, let's just put it in the context of the woman in front of us. When you're pregnant, you have an elevated basal metabolic rate. So women have a higher heat production even at rest. And in general, the first trimester is the most affected because that's when they're building the placenta, and that's a really high metabolic time period. But in general, throughout the entire pregnancy, they have a higher metabolic rate. So compared to a non-pregnant person, a pregnant person will already be having a higher internal heat production because of the metabolic demands of the pregnancy. Hydration is really important in pregnancy. Remember, they have that huge increase in blood volume. So their body is actively trying to build a blood volume. If you are exercising in the heat and relying on evaporation, they have to drink even more. And that's a really important thing to educate women on, because they feel like they're drinking water all the time already. So they might underestimate their hydration needs if they're adding exercise on, or they're like, this lady maybe went on vacation and she's going to go run while she's on vacation and isn't thinking about the heat. Dress appropriately to allow the maximal benefit of your heat dissipating mechanisms. And then I would talk to these women that you're treating, if they're doing a higher intensity aerobic exercise using a lot of big muscles, the heat and humidity might compromise their ability to, exercise at the same intensity, exercise for the same length of time, and feel comfortable explaining why that is. So the ACSM's FIT recommendation for pregnant women is very similar to a healthy normal. If you look in the aerobic category, the biggest difference is in intensity. You will see that the vigorous intensity option is not included in the recommendation. So the frequency is the same, the time is the same, the choices of mode are almost the same. There is maybe a slight caveat to activities that limit the risk of abdominal injury. So if they're playing a sport where a ball is being kicked or thrown, that might not be the best option because of the risk of direct impact to the abdomen. But otherwise, the only difference in aerobic activity is the intensity piece. When we go to the resistance, again, we see just lower intensity. So submax reps, not as intense as a non-pregnant recommendation. And then flexibility is all the same. One extra consideration for pregnant women is their center of gravity is very much affected by the pregnancy, and they are considered a fall risk. The change in the center of gravity, which happens relatively quickly, coupled with the laxity of the passive stabilizers of their joints, causes a reduced joint stability that can make them more likely to fall or not tolerate activities that have a really high balance component. So you just want to think about what you're prescribing. If you're not prescribing, if balance isn't your goal, then maybe just don't even prescribe an exercise that has a high balance component. Certainly you can do balance training in a pregnant woman, but a lot of these problems go away as soon as the baby's gone. So it's not normally the goal of the therapy. So it's just a lot of times better to make sure you're prescribing exercise that doesn't have kind of anything tricky in terms of balance. For extra considerations, for a pregnant woman specifically, when might you stop? And we had a kind of our list of cardiovascular reasons to stop. If a pregnant woman is exercising and her shortness of breath is disproportional to exertion, reason to stop. Chest pain, feeling faint or dizzy, muscle weakness, vaginal bleeding or amniotic fluid leaking. Amniotic fluid leaking would kind of feel like the woman wet her pants, like she had an accident, but it wouldn't have the smell of urine. Sometimes that can be tricky because women will be like, oh my gosh, I just peed my pants, but it doesn't smell like urine. That should be a red flag. Most pregnant women are not peeing their pants typically. So just wanted to make sure, if you have not yet been pregnant, that you didn't think this was something that just happened all the time. But it feels like that. So women will describe their water breaking, and they'll think that they actually just peed their pants instead. Calf pain or swelling, if they have decreased fetal movement, has to be on here, and it bugs me every time because babies do not move constantly. In fact, if you're concerned about a baby, you lay very still. I can't remember the time anymore. It's 40 minutes, and you count how many movements in 40 minutes or 30 minutes or something. So I would be hard-pressed to find a pregnant lady that mid-run is I think the baby's moving less, but you get the point. If the exercise is in any way compromising normal baby movement, that would be a bad sign. And if they go into preterm labor. Let's answer our original question about Sarah. Is it safe for her to exercise? Can she exercise? The answer should not be a straight yes or no, because at this moment, you do not know if she can exercise. You want to review if she has any of the absolute or relative contraindications. If the answer is no, and she does not have any contraindications to exercise, then yes, she is safe to exercise. Next question in your notes, if you see on the top of my page numbers probably aren't the same, but on this under the case study, should you include a warm-up? What do you think? Would it be beneficial? Absolutely, you should include a warm-up, same as any other patient, to get all the same benefits of the heat and the blood flow to benefit your patient and make them tolerate therapy better. Number 3 is an important one. Given her pregnancy, are there any expected abnormal responses? And an expected abnormal response is no cause for concern. An unexpected abnormal cause should raise huge concerns. So what are we expecting to happen here? Is there anything that's going to be different from a normal patient, but normal for a pregnant patient? I would expect that she is going to have a higher than normal resting heart rate. So if she's sitting in front of me and her heart rate is 80 beats per minute, I am not concerned that there's something going on that I can't prescribe exercise. I expect a higher resting heart rate. Blood pressure, though, should be normal. If her blood pressure is abnormal, that's actually one of the contraindications to exercise, pregnancy-induced hypertension. Her breathing rate should be normal. The frequency of her breathing should not be affected, although I would expect a higher tidal volume because she makes up for the volume or the total oxygen needs with volume over rate, but she may have more shortness of breath than a non-pregnant person. And that really has to do with that increased work of the diaphragm. So while a pregnant person can get the same appropriate volumes in and out, they can maintain oxygen appropriately. There's no compromise in blood oxygen levels during exercise. The motion required to move the air in has a greater work demand than someone who's not pregnant because they got to push against that big bowling ball in their tummy. So she came for hip. So let's think about, is there anything, if we're going to start doing some kind of like resistance therex stuff with her, is there anything I should limit myself with if I'm prescribing exercises for her hip? Trying to see if in the case study it told us where she is. From this picture, I can tell she is at least somewhere in the second trimester. So I would say no supine because of the compromise of cardiac output and potentially even that atelectasis in the lungs. I'm not going to include anything that has some serious balance components because she might be affected by the pregnancy and it might impact her ability to be successful in a strength training exercise where my goal is to increase strength, not challenge her balance. This is probably less important when prescribing exercise, but you don't want any really long-term motionless standing. So if you had her standing, that would be like more of an upper body exercise. If she's going to be standing in one place for a long time, blood can pool in her feet and it can increase edema, so mobility is better. If you do any aerobic exercise should never reach exhaustive levels. So we stay in that moderate intensity, and maybe I would favor kind of a non-weight-bearing activity to decrease risk of injury of some kind. So those may be some things that are crossing my mind when I'm thinking about how to give this patient hip exercises. Some of my favorites might be off the table because of the limitations of the pregnancy. The next question in your notes says, should you include a cool down? Which is a good question. It's actually the part of the answer is given to you. It says it prevents an acute drop in blood pressure. Let's just talk that one through and make sure everybody understands that piece. So he said, doing a cool down prevents a drop in blood pressure. So we're trying to prevent a decrease in BP when you stop the exercise. And the reason you care about that is because if blood pressure drops, there's a chance the patient could faint. And we do not want fainting. So why are we talking about this? Why would that even happen? Well, during exercise, what is happening to the cardiovascular system? Stimulated with the sympathetic nervous system and all this skeletal muscle pump driving blood back to the heart, and we see this nice big increase in cardiac output. I should maybe put it at the top, during exercise. Big increase in cardiac output. All of the metabolism of these big muscle groups causes this local vasodilation. This is that normal response, this cardiovascular stuff coming back. That's great. That delivers more blood and oxygen to our muscles, and our heart can pump it because we are amazing and physiology rocks. Then you stop exercise. When you stop exercise, what happens almost right away? You drop your cardiac output because there's no reason. You don't need to keep it high. We got neural innervation of our heart, so we can turn that light switch off and start dropping heart rate and letting cardiac output come down. What happens to all that vasodilation? It is caused by the metabolites in the muscle. Do those instantly go away? Absolutely not. So when you stop exercise, you still have massive vasodilation, right? The heart can turn off very quickly. The vasodilation is going to take a while. So if you suddenly have a drop in cardiac output and you have this very low total peripheral resistance from the vasodilation, you can get a sudden drop in blood pressure. Blood's going to kind of pool in the extremities with all these vasodilated vessels and not make its way back up to the heart. Blood pressure can drop and it can cause a patient to faint. So having an active cool down prevents this sudden drop in cardiac output, gives a little time to wash away all those metabolites so you don't get as much of a vasodilation, so that when you finally come to a stop, there's not such a dramatic disconnect between what's happening in your peripheral blood vessels and what's happening in your heart. All right, we have just a few more things. I know this one's getting a little long, so hang with me. There's a couple things you want to make sure you ask and know about when you're prescribing exercise after the baby's born. So some postpartum considerations. How the baby was delivered is going to matter a lot. So a natural delivery would be a vaginal delivery. These patients are much more likely to have perineal trauma. The perineum is that surface between the pubic symphysis and the anus, and much more likely to have pelvic floor disruption from the trauma of the baby going through the vaginal canal. So really common after a natural childbirth for women to have heaviness or pressure in the vagina and rectum. It's very common at this point to have leakage of urine, difficulty holding back gas, pain during sexual intercourse might be things that you are helping these women through after a natural delivery. If it is not being done, which in most cases it's not, you should really encourage your patients to ask their doctor, their nurse, their midwife, whoever they're seeing at their 6-week check, to check their pelvic floor contraction. And if they aren't getting a nice, strong pelvic floor contraction at 6 weeks post-delivery, they should be seeing a women's health expert or a pelvic floor expert. I can never remember which one they landed on. This is routinely not being done. So we have to encourage our patients to be advocates. So if you're seeing someone for pelvic pain, low back pain, hip pain during their pregnancy, at some point, tell them this. Say, whatever you do, when you go back for your 6-week check, have them check your pelvic floor contraction. You could help this woman for years and years to come with her pelvic floor. The second delivery type is a cesarean section. The big thing here to remember is this is a person who just had surgery, and sometimes that gets forgotten. Pregnant women instantly become caregiver instead of the person who's receiving the care. But they have all of the things that come with surgery, a lot of pain. It's an abdominal incision, so abdominal muscles can be affected. The pain and the abdominal incision kind of leaves them at risk for pulmonary effects. So we talk a lot about deep breathing to prevent pneumonia. We will talk in cardiopulm how abdominal incisions can relate back to the pulmonary system, but I just wanted to put it on your radar now. These women are normally on lifting restrictions and they can have a lot of scarring. So maybe doing scar mobilization to prevent adhesions can be helpful. The other thing that's not actually on your list, but you should write down, is that these women often also require pelvic floor rehab. It can be ignored since the baby did not come out of the vagina that there was any trauma there, but many C-sections have a very lengthy stage 2 pushing phase when they're trying to push the baby out. And typically the babies don't fit for one reason or another, so they're spending a long time beating up their pelvic floor during that time before they have to go in for the C-section. And just the pregnancy itself also can strain the pelvic floor. So just because someone had a C-section, do not neglect to address that as a potential area that might need help. One slide to remind you to be on the lookout for postpartum depression. Postpartum depression is a more serious form of depression than what's sometimes called the baby blues. Right after you have a baby, there is this huge change in hormone levels. So there's typically some emotional stuff right after, and people can be a little sad a day or two after the baby's born. Postpartum depression is much more intense than just feeling a little sad, and it can usually start somewhere in the first weeks after giving birth, but it can be anywhere in the first year that postpartum depression can take hold. This is like such an intense feeling of depression that can interfere with your ability to care for the baby or handle just normal tasks. You can see some of the evidence of it. If you detect any of this, refer right away, because women, it is underdiagnosed. People think they need to be the happy warrior during this time, and it's all about the baby and not about you. And women need help, and it's much more common than previously thought. So if you detect that someone possibly could be going through postpartum depression, please refer them right away. Tell them to go talk to their doctor. Just a kind of a laundry list to wrap it up of some of the more common musculoskeletal conditions you'll see in pregnancy and postpartum. This should make sense hopefully from the conversation we've had up to this point. A lot of pelvis issues, bony malalignment. We see there's an increased risk of this, the bigger the baby or with traumatic births. So if you're seeing someone postpartum, make sure you ask them their birth story and hear what happened to see what might have transpired. A lot of perineal trauma, diastasis recti and abdominal trauma. The feet and ankles can be very affected because of the laxity of all the ligaments, so they can change their arch support and their ligamentous support. Back pain is huge. I think we've talked about that. And sciatica, and then pelvic floor is here. It's still in the slide. About 80% of all women postpartum experience some form of incontinence. So it's much more common than uncommon. So these women should be getting help. It is not just normal after you have a baby, and we can help these women. You guys are going to get a whole women's health lecture, so you will get a lot more on this, but I just wanted to plug it while we can. Okay, just in case I completely horrified you and made you think that you never wanted to have a baby in your life, well, this picture doesn't help, but this is me a week overdue with my first baby. That is a fake smile. I am very unhappy and very uncomfortable. But about one day after this picture, well, I guess the picture came a couple days later, but this is what popped out, and I guarantee it was all worth it. So just in case I completely scared you away from pregnancy, our bodies are resilient and amazing, and they do bounce back, although some of us need help with therapy and we need proper referrals, but we get to snuggle this little ball of joy in the meantime, and it's all worth it, I swear. Thanks for your attention. I hope you guys are doing well.